Welcome everyone to the ECG CRASH course. Today we'll be going through ventricular arrhythmias. So just a recap of the normal heartbeat, we know that the signals start at the sinoatrial node, which depolarizes the atria, forming our P wave. That signal then goes down to the AV node, which will hold onto that action potential, forming a physiological delay known as our PR interval. That signal then conducts down the His bundle system and depolarizes the ventricles, forming the QRS. The whole thing repolarizes, forming the T wave, and that forms our normal sinus beat. But what if, instead of the signals coming from the sinoatrial node, what if they came from the ventricle instead? What if they came there, or anywhere in the ventricle? What will that look like on an ECG? Well, you'll see something called a ventricular ectopic, or VE for short, or a premature ventricular complex. And these are basically funny looking beats which are broad, so they're greater than 3 small boxes, they're a weird shape, and they're usually followed by a compensatory pause. And a compensatory pause is basically this sort of break that occurs after the beat. And usually they come in early as well, which is why they're called premature ventricular complexes. So there's different classifications of ventricular ectopics based on the pattern they show up. So using the example we saw earlier, if you see a ventricular ectopic on its own, we call that an isolated VE. If you were to see 2 ventricular ectopics occurring consecutively after each other, we'd call that a couplet because they're like a couple. If you were to see 3 ventricular ectopics occurring one after the other, we would call that a triplet. And this is an example showing couplets and triplets existing with each other. And if you were to see more than 3 ectopics, in this case we see 1, 2, 3, 4, 5, we would call that a salvo. A salvo, it can also be called, in some cases, a non-sustained ventricular tachycardia. But salvo is also used as well. One thing to note is that ventricular ectopics can look all various shapes and sizes, and they don't necessarily have to all be the same morphology or monomorphic in nature. They can look polymorphic, and that's because you can have different ectopics coming from different foci within the ventricles. So that's just something to be aware of. So there's some other patterns to be aware of, and they're quite simple once we go through a few examples. So in this case, we can see a normal sinus beat followed by a ventricular ectopic, followed by a normal sinus beat, followed by another ventricular ectopic, followed by a normal sinus beat, followed by another ventricular ectopic. So we have this 1-to-1 ratio of normal and abnormal, and we call this ratio a ventricular bigeminy. So you'll see an abnormal and a normal pattern of ventricular ectopy, and in this case the ventricular ectopy seems to be monomorphic in nature. So these VEs generally look the same shape, so it's probably one ectopic foci somewhere in the ventricle that's intermittently firing off. If you look at this next example, we can see a normal beat, followed by a ventricular ectopic, followed by a normal beat, ventricular ectopic, normal beat, ventricular ectopic. So for every third beat's basically abnormal, and we call that a ventricular trigeminy. And again, in this example, each ventricular ectopic seems to be the same morphology, so it's likely the same foci that's intermittently firing off. You can have ventricular bigeminies and trigeminies where the morphology of the ectopy does change, and that's just because it's just a different foci that's firing off within the ventricle for each beat. So something to be aware of is something called an aberrant beat. With this example here, this might look like a ventricular ectopic because it's broad, it's a funny shape, it doesn't look like the intrinsic beat, it comes a bit early, and it's followed by a compensatory pause. This however, isn't a ventricular ectopic. this is something called an aberrant beat. And what aberrant beats essentially are they're basically an early atrial impulse that's basically gone down to the His bundle system when it hasn't fully repolarized. And that's why you get that broad complex, because there's sort of like a funny delay that's occurring, which forms a weird looking QRS. And good way to really recognize them is that you might see a sort of a funny looking P wave preceding the weird looking beat, and that will usually give it away that it is an early atrial impulse as opposed to something coming from the ventricles. But if you were to call this a ventricular ectopic, I think it wouldn't make that much of a difference to the patient, but it's something to be aware of. So now time to look at the ugly, and by the ugly I mean ventricular arrhythmias that can kill a patient. So the first one we're going to cover is ventricular tachycardias. So what's a ventricular tachycardia? Well, using this example here, it's a broad, it's a rhythm that's fast. The QRSs are broad, greater than 120 milliseconds, and in this case, they can be fairly regular. So when I say regular, the R to R interval between each beat doesn't change much. They're fairly similar. In this case, this is a monomorphic VT because the morphology of each ventricular beat is the same. You can also have examples of polymorphic VT where the QRS morphology varies between each beat. This specific example here, we can see a sinus beat followed by two ectopics, which are a couplet, followed by a sinus beat, followed by an isolated V, followed by a sinus beat, and then you get this nasty run of polymorphic VT. This specific example is something called torsades de pointes, which is French for, I believe, turning of the peaks or something like that. And this specific example may be something, may be associated with certain syndromes such as long QT syndrome. Other causes of VT is long QT, which has various different causes which you'll learn in your placements. Certain medications can cause long QT. There can be congenital abnormalities such as long QT syndrome that can cause long QT. And then other things are things like myocardial ischemia. For example, if a patient's having a STEMI or an NSTEMI, check the video out if you don't know what a STEMI or an NSTEMI is. And if patients are having, if patients who have existing pre-existing myocardial scar, which could be due to an old myocardial infarction, or if they have certain types of cardiomyopathy, which has generated scar, you can get re-entry circuits formulating within the ventricle itself, which can create these nasty ventricular tachycardias. So that's just something to be aware of. More advanced ECG interpretation can help you distinguish VT from other sort of more benign rhythms. And that specific criteria is called Brugada criteria. However, that's outside of the scope of these videos. So why is VT dangerous? So this echocardiogram represents it quite nicely. So this is the left atrium, this is the right atrium, this is the right ventricle, and this here is the left ventricle. And the left ventricle, these are the left ventricular walls here, and you can see that they're contracting really fast and they're not really pushing out any blood. And that's the reason why when VT is really fast, you generate barely any cardiac output, and that's why it can cause a cardiac arrest. And the treatment for a VT is to get a defibrillator and give the patient a nice shock to reset the heart and hope that sinus rhythm takes back over, and you basically break the re-entry circuit. So the other nasty rhythm is ventricular fibrillation, and this ECG represents it quite nicely. It is basically an ECG that looks like a bunch of scribbles. There is no real clear morphology, and the ventricle is basically just quivering. There is no cardiac output because the ventricles are just quivering, and that's again a nice example. This is the left ventricle, this would be the outflow tract, this is the aorta, and this is the aortic valve. It's not opening because there's no cardiac output, and the ventricle is just quivering. So and that's again, it's another rhythm that causes a cardiac arrest. And what is the treatment for ventricular fibrillation? It's to shock the patient back out of it. So time for some practice questions. So feel free to pause the video to go through them and work them out yourself. I'll just pop the answer up. So the first question is, a patient on a cardiac day case unit complains of feeling very dizzy. The nurse takes some quick observations and his blood pressure is 78/55. You request an ECG to be done immediately. This is ECG. So this is all in the context of a patient with who's very hemodynamically unstable. So the answer is coming up in 3, 2, 1, 0. So this is an example of monomorphic VT, and if you worked out the rate, it's going at a rate of around about 200 beats per minute. And then I've mentioned something called a capture beat and a fusion beat. So well done if you got that right. We'll go through it now. So we can see this massive run of VT here, and it's fairly monomorphic in nature, and that will definitely be what's causing such a rubbish cardiac output and blood pressure. So what are these capture beats and fusion beats? So capture beats, which you might have noticed this normal looking beat here, it's a beat that's managed to actually come from the atria and conduct successfully down the His bundle system and cause the ventricle to contract. And that's what creates this narrow QRS within you could say, VT storm. And that's a capture beat. A fusion beat, if you go along, is this funny looking beat here. And a fusion beat is basically similar to a capture beat. A atrial impulse has successfully gone down the His bundle system. However, it's only partly made its way down, and it's actually fused with a ventricular beat that's occurred at the same time, creating this amalgamation of a beat called a fusion beat. So well done if you got that right. And let's move on to the next example. So you're one of the FY2s in A&E, and the patient complains of palpitations. You decide to do an ECG. Here's his ECG. Feel free to pause the video and work it out yourself, otherwise the answer is coming up in 3, 2, 1, 0. So this is sinus rhythm with one salvo lasting 4 beats and a cycle of ventricular bigeminy. Well done if you got that right. Let's go through the answer. So this is sinus rhythm because you can see a P wave, a QRS followed by a T wave. So we know that's of sinus of origin. We know that the origin is sinus. We then see a ventricular ectopic followed by a normal beat, followed by ventricular ectopic, followed by a normal beat, followed by ventricular ectopic. This is the ventricular bigeminy that we commented on. Then that's followed by 2 sinus beats, followed by a run of 4 ectopics, which is a salvo. If we wanted to be extra clever, we could say they're all monomorphic in nature, so this is likely the same ectopic focus within the ventricle that's creating all these beats. Well done if you got that right. So next example, a patient comes into A&E complaining of palpitations and feeling dizzy. He takes indapamide. You request bloods and an ECG. Here's his ECG. So feel free to pause the video and work it out yourself, otherwise the answer is coming up now. So this is sinus bradycardia with a long QT interval, around about 0.6 seconds, with an episode of non-sustained VT lasting 7 beats, which could be interpreted as tossards the point. So well done if you got that right. If not, we can go through it together. So firstly, establish if it's sinus. We can see a P wave, a QRS followed by a T wave, and we can see that for each of these beats. And if you're to work out the rates, it is sinus bradycardia. So we can see that the QT interval, if we're to measure it from there to there, it looks fairly long, and if you were to work it out, it comes out as 0.6 seconds. So we mentioned earlier that having a long QT interval is a risk factor for having a towards the points episode. And basically, there's certain cutoffs for QT intervals for both men and women. For men, it's anything greater than 440 milliseconds, which would be classified as long QT. And for women, it's anything greater than 460 milliseconds. That can be classed as long QT. And generally, anything greater than 500 milliseconds is classed can be put you at a risk of having towards the points. In this case, the QT is 0.6 or 600 milliseconds. And obviously, then we can see this tasty run of VT, and we would calculate it, count how many beats there are: 1, 2, 3, 4, 5, 6, 7, and you just comment on how many beats it's lasting. So in the script, we can see that the patient takes indapamide. Now, indapamide is a drug that can basically cause hypokalemia, and it can cause hypokalemia, and hypokalemia can cause QT prolongation, and that's probably what's caused this patient to start having torsades de pointes, which is causing his palpitations. So it's about linking the patient's symptoms, the bloods, and the ECG together. Obviously, in the script, the bloods haven't come back yet, but hopefully when they come back, you'll see that there's a hypokalemia, and then you'll be able to tie everything together. So last question: you're in FY1 managing a bay of patients on a cardiology ward. One of the annoying monitor alarms starts bleeping for one of the patients, and you look at it, and this is the ECG you see. Feel free to pause the video and work it out yourself, otherwise the answer will come up in 3, 2, 1, 0. So sorry if anyone said VF, even though the monitor is kind of screaming VF, and I did say VF did look like a bunch of scribbles. However, this is just some artifact which will likely catch a lot of people out. Well done if you didn't get caught out by it. So the way to work out that it's artifact is that, firstly, you can see 2 narrow beats here, and if you look closely, you can see a narrow beat there, you can see a spike there, you can see a spike there, and you can see a spike there, and you can see a spike there, and a spike there, and a spike there. These are basically normal beats with artifact superimposed on them, and even here you can see a narrow spike there. And if you were in doubt, just check that the patient's breathing and hasn't cardiac arrested, but it's likely the patient's just fiddling around with the wires of the ECG, which is causing the artifact to occur. So I just thought I'd chuck that in because just for some entertainment, really. So thank you for watching the video. I hope you found it useful, and check out my other videos on ECGs as well. Catch you in the next one.